Usually when we talk about a medical diagnosis, there's this expectation of precision. It feels almost like engineering, right?
Well, absolutely.
Like you break your arm, the X-ray shows that jagged white line, the doctor points to it and says, "There it is. That is the problem."
Right. It's totally binary. I mean, it's broken or it's not breaking. And
Mhm.
honestly, we find that incredibly comforting. We like things to be visible, neatly categorized,
Yeah.
and to just have a single, straightforward fix.
Yeah, exactly. But then, and this is what we're talking about today, you step into the world of maternity and women's health, and suddenly that X-ray machine is just useless.
Completely useless.
We're looking at a landscape that is, honestly, completely murky. It is incredibly complex, deeply human, and highly unpredictable. And that is exactly what we're getting into today.
Welcome to today's deep dive. We are so glad you are here with us.
Yeah, thrilled to have you here. So today, our mission is to explore the modern landscape of maternity and women's health. We've been looking through the foundational clinical data, right? The actual frameworks and models that train today's nurses and providers. And what we found isn't just a clinical guide on how to deliver babies.
No, not at all.
It's actually a mirror. It's reflecting exactly how our society handles its most vulnerable moments. Birth, life, health, all of it.
And, if you are listening to this right now thinking, well, I'm not a nurse, and I am definitely not planning on having a baby anytime soon, so why does this matter to me?
Right, the classic question.
Exactly.
Yeah.
I highly encourage you to stick around because this deep dive explores the surprisingly complex, high-stakes system that brought you and literally everyone you know into the world.
Exactly. Understanding this machinery is, well, it's fundamental to understanding modern healthcare. It affects economics, policy, basic human rights. So, okay, let's unpack this.
Let's do it.
The very first thing that jumped out at me from these foundational frameworks is how the actual definition of this field has just completely shapeshifted. I mean, it used to be just about the delivery room, right? You go in, you have a baby, you leave.
Yeah, a very isolated event.
Right. But the modern clinical model outlines this massive shift toward what is called a reproductive life plan.
And that is a crucial paradigm shift. The care is no longer viewed as just an event. This reproductive life plan is defined as a compilation of goals related to a person's decisions regarding whether to bear a child or not.
Yeah.
And it spans this massive timeline. We're talking from the preconception period all the way through pregnancy, birth, and then the first 6 weeks postpartum.
And the current models specifically note that this continuum of care now explicitly includes transgender individuals, too.
Which is huge.
It really is. It highlights how the definition of who receives this care is broadening to reflect the reality of society. Now, before we get any further, I do need to pause and issue a quick disclaimer to you listening.
Yes, very important.
Because this field deals with the origins of human life, the clinical data we're looking at naturally intersects with several intensely politically charged topics.
Right.
The modern frameworks discuss the 2022 Supreme Court overturning of Roe v. Wade, the impacts of the Affordable Care Act, or ACA, and systemic racism in healthcare.
That's exactly right.
Uh-huh.
And to be absolutely clear here, our role today is not to take any political sides or to endorse specific viewpoints.
Exactly. We are not here to debate the politics. Our job is strictly to strip all that away and impartially report on what the medical data, the statistics, and the frontline nurses are actually reporting.
Just the facts.
Just the facts.
Yeah.
So with that understood, to really grasp why this modern reproductive life plan exists, we first need to look at how rapidly this field has evolved, because the history here is wild.
Oh, it really is. When you look at the timeline of medical milestones, it's practically a history of human survival.
It is. Just consider a few of these historical data points we pulled. In 1847, a doctor named James Young Simpson in Scotland used ether for childbirth.
1847.
Yeah, 1847. It was the first reported use of obstetric anesthesia. I mean, before that, childbirth was essentially an exercise in enduring unimaginable, unmitigated physical trauma.
It's hard to even fathom.
Right. Then, jump to 1934. The Dion quintuplets were born in Canada. The sheer statistical unlikelihood of 5 babies surviving early 20th century medicine is staggering. But they managed to survive partly thanks to the utilization of donated breast milk.
Which is incredible.
And then in 1953, Virginia Apgar, an anesthesiologist, introduced her famous neonatal scoring system.
Right, the Apgar score. And what's fascinating here is the underlying mechanism of change that these milestones reveal. We're looking at a profound evolution in medical philosophy.
How so?
Well, Virginia Apgar's scoring system is the perfect example. It's a simple checklist, right? Heart rate, breathing, muscle tone. But how it changed medicine is monumental. Because before the APGAR score, the infant was often treated almost as a well, like a byproduct of the mother's labor.
Oh,
Yeah. If the mother survived, it was considered a success. But APGAR's system forced doctors to look at the newborn as a distinct, vulnerable patient, requiring immediate, proactive assessment.
so the focus shifted from just surviving the trauma to actively measuring and improving the outcomes.
Ex-
I was trying to think of how to visualize this shift, and it kind of reminds me of a financial retirement portfolio.
oh, that's an interesting comparison. How does that work?
Well, historically, giving birth was like dealing with a sudden, massive financial emergency. You just reacted to the event when it hit you, and you hoped you didn't go bankrupt or, in this case, die.
Right. Totally reactive.
But today, with this reproductive life plan, it's like a lifelong retirement strategy. You're planning years before the event happens, you are monitoring all the metrics during the process, and you are managing the long-term aftermath. It's no longer just reacting to a crisis, it is a continuous, proactive strategy.
That is a highly accurate analogy. It perfectly highlights the transition from episodic care to continuous management. But, and this is a massive but, in the data that transitioned to a highly managed, technologically advanced system has created a rather alarming modern paradox.
Oh man, the paradox is staggering. Wait, hold on, because this part completely blew my mind.
Yeah, it's tough.
In 2020, the United States spent almost 20% of its gross domestic, wait, let me get the exact number, 19.7% of its GDP on healthcare.
Almost fifth of the economy.
Exactly. We have all these incredible medical advancements, the anesthesia, the monitors, the data, yet the maternal mortality rate in the U.S. has actually doubled over the past 2 decades. Doubled. How is that mathematically possible?
It defies basic logic, right, until you look at how the system actually operates. The data shows that the U.S. has the highest maternal mortality rate compared with other developed countries.
The highest.
The highest. And when it comes to infant mortality, the U.S. ranks 11th among industrialized nations.
So what does this all mean? Like, we spend a fifth of our national wealth on healthcare. If we have all this advanced technology, why are the outcomes in these specific areas getting worse? Are we just over-relying on machines instead of human care?
The clinical research offers a very clear explanation for this. It points to a healthcare delivery system that is highly fragmented, exorbitantly expensive, and totally inaccessible to many.
Right.
The fundamental issue is that our system leans incredibly heavily on high technology, reactionary care, while systematically neglecting basic, fundamental preventative access.
There was a detail in the research that perfectly illustrates this, and it really made me pause. It noted that in virtually all hospital births today, labor is monitored electronically using continuous fetal monitors.
The belts they put on your stomach.
Yeah, but it also noted there is a distinct lack of evidence regarding the actual efficacy of such widespread monitoring. So why do we do it? Are we just strapping monitors on people because the tech exists?
Pretty much, yes. And the mechanism behind why that fails is crucial. Continuous electronic fetal monitoring often produces a false sense of security, or worse, false positives.
Oh, like it says something is wrong when it isn't.
Exactly. A slight normal variation on the monitor might be interpreted as distress. That leads to a cascade of interventions. Suddenly, the patient is rushed into an emergency C-section, which carries major surgical risks, infections, and longer recovery times.
And more cost.
Astronomically more cost. But here's the kicker. If a mother doesn't have access to basic prenatal care in her first trimester,
Yeah.
or if her Medicaid coverage drops off immediately after birth, so she has no follow-up care in the postpartum period, which, by the way, is when many fatal complications occur, all the high-tech monitors in the world during the actual labor won't save her.
The foundation of basic access is just missing.
It's completely missing.
And if the high-tech machines aren't saving us, what is the data actually pointing to as the root cause of these fatalities? Because the foundational data does not shy away from answering this. It points directly to stark racial disparities.
It does. The biostatistics are highly specific, and they paint a deeply concerning picture of who is actually surviving this system.
The numbers are just shocking. Black women face a 3-fold to 4-fold increase in the likelihood of dying as a result of a pregnancy-related condition compared to non-Hispanic white women.
Yeah, 3 to 4 times higher.
But surely, I mean, socioeconomic status plays the defining role here, right? Like, playing devil's advocate for a second. If
Mhm.
you have a higher income and can afford better insurance and better care, wouldn't your outcomes improve regardless of your race?
That is the exact assumption that many people make, but the data completely dismantles it.
Really?
Really. And this is the most critical statistic. Even college-educated black women have a maternal mortality rate that is 5.2 times higher than college-educated white women.
Okay, let's unpack this because that breaks the entire assumption. If it were just about education or money, the outcomes for college-educated individuals would equalize,
Right.
but they don't. They actually get worse. So how do the medical experts explain this?
The clinical consensus explicitly states that these disparities are not due to race as a biological factor. They are due to systemic racism.
Okay.
And again, to maintain our strict impartiality and just report the facts, the medical frameworks utilize a definition from the Aspen Institute, which is a non-ideological think tank, to explain exactly how this works.
What's their definition?
They define systemic or structural racism as a system of public policies, institutional practices, and norms that work to perpetuate racial group inequity.
Wow. Okay.
It identifies dimensions of history and culture that allow privileges associated with whiteness and disadvantages associated with color to endure. That invisible architecture, how pain is assessed, who is listened to, how policies are structured, is the root cause identified by the medical community for these specific mortality disparities.
It's a heavy realization that the structure of the system itself is the primary risk factor. But what I really appreciated is that the data doesn't just present the problem and walk away, right?
No, not at all.
It details how frontline workers are fighting back. Like, it highlighted groups like the Black Mamas Matter Alliance, which advocates for policy changes framed through the lens of reproductive justice.
And it also details the listening sessions conducted by the National Commission to reduce racism in nursing.
Yes. Their recommendations were fascinating because they weren't just asking for a bigger budget or something. They were demanding cultural shifts within the profession.
Oh, absolutely.
They recommended explicit mentorship programs for nurses of color, genuine accountability at the organizational level, and allyship from others who need to actively, unlearn biased behaviors. They are demanding that racism be called out in real time at the bedside. It's very actionable.
It is. And it shows that faced with massive systemic issues and a highly fragmented system, providers are realizing that the old ways of operating are literally lethal. They're actively trying to change their daily practice to keep patients safe.
Which brings us to how the actual architecture of medicine is changing. Because it's not just about policy, it's about what happens in the hospital hallways every single day. There's a huge push towards something called interprofessional education, or IPE.
Yes, IPE is a major structural shift. If we connect this to the bigger picture, historically, medicine was incredibly siloed.
Like everyone in their own lane.
Exactly. Doctors trained only with doctors, nurses trained with nurses, pharmacists with pharmacists. It was like an assembly line where no one talked to the person next to them.
Right.
But a patient isn't just a set of isolated organs. IPE forces these disciplines to train collaboratively from day one. If a baby is born with a congenital anomaly, you cannot afford miscommunication. You need the neonatologist, the bedside nurse, the social worker, and the genetic counselor, all communicating seamlessly, understanding each other's roles.
And they're communicating beyond just traditional Western medicine, too. We're seeing the rise of integrative healthcare.
Yeah, that's a big one.
This blends conventional medical treatments with alternative modalities like acupuncture, biofeedback, or massage therapy. It seems like the system is finally trying to treat the whole human being.
Finally.
We also see this in the rising utilization of midwives and doulas. As of 2015, midwives attended about 8.1% of births.
And the data indicates exactly why that is happening. Women who use nurse midwives often participate more actively in their care and generally receive fewer medical interventions during labor, which avoids that whole cascade of technology we discussed earlier.
But, even with a great collaborative team, things still go catastrophically wrong. And here is where the reality of the hospital floor gets terrifying. Medical errors. The data states that medical errors are the third leading cause of death in the United States.
Third, it's a profound systemic vulnerability.
Here's where it gets really interesting, though. When we think of a fatal medical error, we usually picture something highly dramatic.
Like a surgeon operating on the wrong leg.
Yeah. Or a machine explodes. But modern safety protocols zero in on something incredibly mundane. There is literally a Joint Commission do not use list of abbreviations.
Yes, I know this list well.
I was reading this list, and it's things like, you aren't allowed to write the letter U instead of the word unit, or you can't leave a trailing zero, so you can't write 2.0 milligrams. You are strictly required to write 2 milligrams.
Yep, very strict rules.
I have to push back here. How does a stray decimal point or a single letter U cause a literal life and death medical emergency?
It is a great question, and it goes right to the heart of how human cognition interacts with high-stress, high-stakes environments. You have to picture the reality of the job.
Okay, paint the picture.
Imagine an exhausted, overworked nurse reading a hastily written patient chart at 3 a.m. The lighting is low, alarms are beeping everywhere. If a doctor scribbles 10U for 10 units of insulin, but that U is written sloppily and looks a bit like a zero.
Oh my God, the nurse might read it as 100.
Exactly. Suddenly, the patient is injected with 10 times the lethal dose of a medication.
Mm-hmm.
Or with the trailing zero, if the decimal point in 2.0 is faint and isn't seen, it instantly becomes 20.
Wow.
Yeah. These tiny, seemingly bureaucratic documentation rules exist because a single misread character can bypass all the billion-dollar high-tech machinery and kill a patient instantly.
Okay, when you put it like that, it makes total sense. It's the human element failing under the weight of a complex system, and that connects to a concept that absolutely stopped me in my tracks. It's a specific clinical term called failure to rescue.
Yes, that is arguably the cornerstone concept in modern nursing safety.
The clinical definition of failure to rescue is the failure to recognize early signs of distress and activate a team response. I was thinking about this like an airplane's dashboard.
How so?
The fatal event isn't the engine blowing up. The fatal event is the pilot ignoring the tiny, blinking yellow warning light on the dashboard 20 minutes earlier. It's not about the catastrophic hemorrhage itself. It's about missing the quiet, subtle clues leading up to it.
Precisely. In modern nursing, vigilant observation and the willingness to speak up and communicate are just as critical as the medical technology.
So it's about communication.
Absolutely. If a fetal monitor shows a slight change, or a patient's blood pressure drops marginally, but the care team fails to interpret it, or they are too intimidated by the hierarchy to communicate it to the attending physician.
That's failure to rescue.
Yes, they have failed to rescue the patient from the impending complication. The window to act closes.
That is heavy. It is entirely about paying attention to the whispers before the scream. And of course, healthcare isn't limited by the walls of a single hospital or even by national borders. When the data zooms out to look at the global frontier, the statistics are incredibly grim.
The global health metrics really put the domestic U.S. data into a much broader, starker perspective.
Every single day, globally, 7,000 babies die within 28 days of birth. 7,000.
It's heartbreaking.
And the data highlights massive human rights violations that intersect directly with healthcare, like human trafficking and female genital mutilation. It notes that an estimated 513,000 women and girls in the U.S. alone have experienced or are at risk for female genital mutilation.
And as healthcare providers adopt a more global perspective, they are increasingly the ones on the front lines identifying these survivors.
Right.
A woman might come into a clinic or an emergency room for a completely unrelated issue, and the nurse is the first person in years to recognize the signs of trafficking or abuse.
But amid all that darkness, there was this one specific detail that I found profoundly inspiring. It highlighted a group of 48 women who literally climbed Mount Kilimanjaro, the tallest mountain in Africa, to raise awareness and funds to combat human trafficking. They raised over $350,000 to fund safe houses, provide prenatal care, and offer microloans for survivors. It just shows how expansive the role of a health advocate can be when they step outside the clinic.
It truly does. It proves that health advocacy transcends clinical settings. But, as the field expands both globally and technologically, this raises an important question, or rather a series of incredibly difficult, unresolved ethical questions.
Oh, the ethical dilemmas presented in these modern frameworks, they sound like science fiction, but they are happening right now in real hospitals.
Exactly. The medical community is currently grappling with scenarios that society has no clear answers for.
Like what?
Well, for instance, with highly advanced reproductive technology, it is now medically possible for postmenopausal women to become pregnant. The ethical framework asks, should scarce, expensive healthcare resources be devoted to achieving pregnancies in older women when basic prenatal care is drastically underfunded?
Wow, and it doesn't stop there. It asks if long-acting contraceptives should be made mandatory for certain vulnerable populations, like individuals with severe substance use disorders, to prevent infants from being born with addictions.
which is a massive ethical minefield.
Yeah. It even asks what the fundamental rights are of a cloned human embryo.
These are scenarios where medicine, law, ethics, and basic human rights violently collide. And the reality is that nurses and healthcare providers are standing right in the middle of these debates, helping real patients navigate impossible choices that didn't even exist 50 years ago.
It is mind-bending. Okay, we have covered a massive amount of ground today. If I had to synthesize everything we've pulled from this deep dive, maternity and women's health nursing today is an incredibly complex, high-wire act.
That's a great way to put it.
You have these triumphant historical milestones like inventing the APGAR score or surviving against all odds with a donated breast milk sitting right next to deep-rooted systemic flaws and implicit biases that cause completely unacceptable mortality rates.
Yeah.
And layered on top of all of that are these futuristic ethical nightmares.
It is a vast amount of information to process.
Yeah.
But I think the most important takeaway for you listening is this.
Mhm.
Whether you are advocating for yourself or a partner in a hospital room, whether you're carefully reading a prescription pad so you don't fall victim to a trailing zero error,
Right.
or whether you are at the ballot box voting on public health policies, understanding the mechanics of this system is quite literally a survival skill.
Mm.
The foundational models emphasize health literacy, which is the ability to obtain, read, understand, and use healthcare information to make appropriate health decisions. In today's fragmented world, health literacy is not an optional skill.
It's mandatory. You have to know how the machine works to survive it. Which brings me to a final thought I want to leave you with today. We talked earlier about that intense medical concept, failure to rescue.
Yeah.
In the hospital, it means the experts missed the early, quiet signs of distress before a catastrophic event happened. They ignored the blinking light on the dashboard. But what if we applied that concept outside the hospital walls?
Oh, I like that.
Think about your own life, your community, or your workplace. Where are the early warning signs of distress that are currently being ignored? Are we suffering from failure to rescue in our own daily systems, just waiting for the emergency to happen? It is something to seriously think about.
A very powerful question to consider.
Thank you so much for joining us on this deep dive. Take care of yourselves and keep paying attention to those early signs.